Good afternoon, and thank you for joining us for today's talk on osteoporosis medications and their side effects, presented by Dr. Frank Benora. Dr. Benora, as many of you know, is a gynecologist practicing here in Smithtown. He's director of menopausal health and also director of the osteoporosis program here at St. Catherine of Siena Medical Center. Before Dr. Benora begins, just a little bit of housekeeping for us. If you do have questions, you can type them into the chat box. Alternatively, you can hold them until the end of the presentation and unmute your mic and ask your question. I am going to keep everybody on mute during the presentation just so that we don't have too much background noise distracting us. And this is our last of our series for the month of May. We will be continuing to have these lunchtime lectures on a monthly basis, and we are looking for your feedback in terms of what topics you're interested in hearing about. So if you do have any suggestions, again, please type those ideas and thoughts into the chat box or hold them until the end and share them with us verbally. We'll also be sending an email around soliciting your feedback and input. So without any further ado, I will turn the floor and the mic over to Dr. Benora to begin. Oh, I don't think we can hear you, Dr. Benora. We need to get your microphone working.
How about now? Can you hear me now?
Now we can.
Okay. This is the fourth of the series of Lunch with the Doctor. Our first two talks, our first two luncheons were the symptoms of menopause, hot flashes, night sweats, and the genitourinary syndrome of menopause and how we treated it. Our last lecture in this lecture is on a major medical problem that occurs in menopausal women and in senior men, osteoporosis. Our last talk, we talked about how we diagnose it, how the diagnosis of osteoporosis is made. Today's topic are the medications that we use for osteoporosis and what the side effects are. Next slide. This slide shows what we do in my private practice. I am a gynecologist, and we specialize in those women in their 40s or older who are in the menopausal transition or who are menopausal. And we treat those women who have hot flashes, night sweats, insomnia that affects the quality of their life, women who have vaginal dryness, pain with intercourse, urinary problems such as urinary frequency, urgency, recurrent urinary tract infections. Next slide. Now to our topic. Next slide. Osteoporosis is a generalized bone disease in which there's a decrease in the mineral content in your bone. There's a change in the microarchitecture. On the left is normal bone, on the right is osteoporotic bone, and you can see how thin it is. And when you fall from a standing height or you stretch your arm, cough or sneeze, your bone is fragile, it breaks. Next slide. This slide was taken in 2002. In 2002, there were 10 million Americans, men and women, who had osteoporosis. Today, in 2020, 10 million women have osteoporosis. 44 million individuals have low bone mass. And of you ladies who are 50 or older, 50% of you will have a osteoporotic fracture in your lifetime. And you men who are watching, and I hope there are some men that are watching, a quarter of you, 25% of you will have in your lifetime, if you're 50 or older, an osteoporotic fracture. Next slide. This slide shows the 1.5 million women who had fractures last year, more than stroke, heart attack, or breast cancer in women. Next slide. These fractures lead to 500,000 hospitalizations, 2.5 million office visits, and 180,000 admissions to nursing homes. Next slide. Now, go back one slide. I'm sorry, go back one slide. Now, there were 2 million fractures last year total. These fractures lead to pain, disability, and death. There were 300,000 hip fractures in men and women last year. Of the 300,000 hip fractures, 145,000 people died from them. Now, there are 2 types of osteoporosis. Next slide. The primary osteoporosis depends on you ladies, your age and your menopausal status, and whether your mother or father had osteoporosis or a hip fracture. Next slide. The second kind of osteoporosis or secondary osteoporosis is due to a medical condition or a drug you're taking. Next slide. Some of the most common medical conditions can be rheumatoid arthritis, COPD, diabetes, kidney disease, lupus, stroke. Next slide. Some of the common medications that can cause osteoporosis is a steroid like prednisone for rheumatoid arthritis. Any antidepressant, any of the diabetic drugs, any of the drugs for cancer, and for breast cancer, any of the aromatase inhibitors, and men with prostate cancers, any of the anti-androgen drugs. Next slide. How we make the diagnosis in our office practice. When you come in your medical history, we look at your risk factors for osteoporosis, and we may do a bone mineral density, we may do a lab workup on you. Next slide. We do a bone density on you or DEXA scan. I hope many of you had a DEXA scan. The problem is less than 20% of men ever had a bone density. Next slide. After you get the bone, and who gets the bone density? If you're a woman 65 or older, you're entitled by the Medicare to have a bone mineral density every 2 years. If you're a man and you're 70 years or older, you're entitled to a bone density every 2 years. If you're 50 to 65 and you're a woman, have any of the risk factors that I just mentioned for osteoporosis, you can get a bone density. If you're a man between 50 and 70 and have any of the risk factors for osteoporosis, you can have a bone density. Next slide. Now, once you get the bone mineral density, if your doctor tells you that your T-score is minus 2.5 or less, you have osteoporosis. If you're 50 or older and a man or a woman and you're standing and fall from a standing height and hit the ground and break any bone, you have osteoporosis. And we call that clinical osteoporosis. Next slide. If you get a hip fracture, man or woman, if a woman gets a hip fracture, in the first year, 25% of you will die. If you're a man and get a hip fracture, 40% of you will die. Next slide. Who should be treated? The National Osteoporosis Foundation tells us if you've ever had a hip fracture or a fracture in the back, you should be treated. If your T-score on a DEXA scan is minus 2.5 or less, you should be treated. Next slide. Now, what are the treatment strategies in women? The same strategies are in men, few men who are watching. What we want to do is strengthen your bone and prevent you from falling and breaking a bone. And the non-pharmacological therapies are, next slide, calcium and vitamin D. Or we need 1,200, if you're 50 or older, you need 1,200 milligrams of calcium a day. Our American diet gives us 600. We need another 600. The best sort of source of calcium would be dairy. 1 glass of milk, 8 ounces, is 300 milligrams. 1 yogurt, low-fat milk, low-fat yogurt is 300 milligrams. 3 ounces of low-fat cheese is 300 milligrams, so you only need a combination of 2. Next slide. If you're a lady or a man who is lactose intolerant, You should take a calcium supplement. They come in 500 to 600 milligrams. You would take only one at a time. Your stomach can only absorb one, and they're best taken with food. Next slide. To absorb calcium, dairy, or to absorb calcium pills, you need to take it with vitamin D. Without vitamin D, you will absorb less than 10% of your calcium pill. And there's really no foods, there are really no foods that are loaded with vitamin D. Some cereals may have it, orange juice may have it added, milk may have it added. And if you're 50 or older, we need, especially if you're menopausal, somewhere between 800 to 1,000 of vitamin D3. And vitamin D is fat soluble. You should be taking it with food. I take it with the major meal, and you leave it on the kitchen table so you don't forget to take it. Next slide. The type of exercises that we recommend is one, weight bearing, walking 1 hour a day, or tennis 1 hour a day. Secondly, muscle strengthening exercises, either free weights or bands or machines, and we recommend flexibility and stretching. Next slide. If you have osteoporosis, we recommend a fall prevention program. One that's great for balance that I do, although my studio is closed, I do yoga, but you can follow it on television. It's free, yoga lessons or Tai Chi. And you should unclutter your house, especially your bedroom, your hallway to the bathroom and bathroom. Leave a nightlight on. Wear at home only rubber sole shoes. Do not wear leather shoes at home because they're slippery and undue clutter. And we wear hip protectors. I explained that last visit, those people who have sustained a fracture of the hip. Now, before we talk about medication, all the medications have side effects to them. What we recommend before you take any medication, and I hope your doctors have done this before they gave you any of the medications, you need a workup to find out, do you have menopause because of your age, menopause and what you inherited, or is it a medical condition you have, which should be treated before you go on medication, or you on a medication that causes osteoporosis, and that should be adjusted before you go on the medication for osteoporosis. Next slide. Now, the drugs that we have are many. We have drugs like Fosamax, Actonel, Boniva, and IV Reclass. What they do is they are incorporated in your bone after you take them. They stay inside your bone. And you take Fosamax, Actonel, and Boniva by mouth. You have to take it, excuse me, on an empty stomach, and you can't lie down for at least 30 minutes to an hour. The other drugs, IV Reclass, is given in an infusion that you get once a year for 3 years. The anabolic drugs, those drugs that build bones, are an injection you give yourself every day for Teo and Tymlos for 2 years. The other major drug that we use is Prolia. That's an injection our nurse gives you underneath your skin twice a year. Next slide. Now, how they work is that Fosamax, Actonel, Boniva, and IV Reclass kills those cells that are in your bone that make the little holes. Prolia does the same thing. It stops the birth of these cells. How Tymlos and Forteo work, it stimulates those good cells that make new bone. Next slide. Our goal for doctors who treat women with osteoporosis and those doctors who treat men is we treat to target. Our target is to move you from osteoporosis to osteopenia. By doing that, we can decrease your fracture risk. And the major drugs that we have to do that now are the drugs that you daily inject, Forteo and Tymlos and Prolia. They're the drugs that increase your bone mineral content in your bone the most rapidly. Next slide. Now, what are the side effects of some of these drugs? Well, if you have GERD, or if you've had a gastric or esophageal ulcer, the side effects of Fosamax, Actonel, and Boniva, which are oral drugs, are gastrointestinal, gastritis, ulcers, and gastric ulcers, and joint pains. You cannot take them if you have chronic kidney disease. The second drug that we use is IV Reclass. It's an IV infusion. The side effect of that is a flu-like syndrome that lasts for 2 to 3 days. Also, if you have bad kidney function, you cannot take IV Reclass. Prolia, the injection my nurse gives you twice a year underneath your skin, is a rash that can occur anywhere over your body that disappears. Forteo and Tymlos, the daily injection you give yourself for 2 years that builds brand new bone, the side effect is dizziness and nausea. That's why we tell you to take it at your bedside when you're ready to go to sleep, because if you get dizzy, we don't want you to fall. Next slide. Now, how long should you take these drugs? We know this, that if you take Fosamax and Actonel and Boniva, the maximum time that you should take that is 5 years, because what happens after 5 years, all the holes in your bones are being filled up. Your bone is becoming over-mineralized and it can become brittle. IV Reclass is usually 3 to 4 doses. That's how long that we take it. The Prolia, you take it repetitively, and the studies go out more than 10 years. Forteo and Tymlos, the daily injection, you only take for 2 years. Next slide. What about a drug holiday? A lot of patients ask me, Dr. Minora, do I have to take this the rest of your life? We say no. After 5 years of Fosamax, we can stop the drug and wait 2 years to see what's happening. With Actonel, after 5 years, we stop the drug and wait to see what happens in a year. After IV Reclass, we can stop the drug after the 3rd or 4th dose and see what happens after 2 to 3 years. With Prolia, we cannot stop the drug. There is no drug holiday. With Tymlos and with Forteo, there is no drug holiday. And what a drug holiday means, it's not that you're going to stop it for the rest of your life. It means we're going to stop it temporarily. Next slide. Now, how can we tell whether you have to go back on the drug or not? We do bone turnover markers after 2 years after you stop taking Fosamax. We do a bone turnover marker every 6 months. What bone turnover markers are chemicals that mean that the cells that are breaking down your bone have woken up and are working again. With Actonel, after 1 year, we do bone turnover markers to see if we need to put you back on a drug. With IV Reclass, it usually works for 2 to 3 years, and the bone turnover markers remain normal until that time. Next slide. A lot of people say, hey, Dr. Minora, I'm afraid to take Fosamax, Actonel, IV Reclass, or Prolia. I'm afraid of osteonecrosis of the jaw. What osteonecrosis of the jaw is, it's a condition in which you get a tooth pulled and it's 8 weeks and the hole did not heal. And the reason for it is you have a lot of germs in your mouth, and this constant trauma of chewing makes it a site for that area not to heal. And what we have found, the original studies found, the people that developed osteocrosis of the jaw were those women who had metastatic bone disease from breast cancer and people who had bone cancer, and they were taking quadruple the type of dose every 3 months of IV reclass. But the studies that show today, the incidence with the drugs that we use for osteoporosis can be 1 to 5 per 10,000 to 1 to 5 per 100,000. And the recent study on Prolia showed that there's 5 cases, 5.2 cases per 10,000 men and women that we give Prolia to. That's less than 1 in 10,000. And next slide, what the American Dental Association recommends, and we do it in our practice, before we put you on any drug for osteoporosis, we make sure that you go to a dentist and have your dental checkup. I go every 3 to 4 months to get a tooth cleanings. So for me, it would not be a problem, but we recommend it. And the American Dental Association said, you really should not stop any dental care because you're on one of these drugs. And one of the ladies asked last time, she's on Fosamax, and a dentist said that she should go off the drug for 3 months. Obviously, her dentist does not look at the American Dental Association website. Fosamax has a half-life in your bones of 10 years. It has a half-life in your bones for 10 years. The wrap-up. What is the takeaway? Now, I lecture. I've been lecturing in the medical school for many, many years. Most people can only remember 3 things in a lecture. The 3 things that you have to remember is that osteoporosis is a very dangerous disease. I can prevent it in your grandchildren. I cannot cure it with medications 100% of the time. Secondly, if you're 65 or older in a lady, 70 or older in a man, or if you have any risk factors for osteoporosis, you're entitled to a bone density. Get a DEXA scan. And if you have osteoporosis, the drugs that we have for osteoporosis are safe to take, providing you have a workup first, a laboratory workup for it. Lastly, it's important that you take calcium every day. The best source is dairy if you can take it, always low fat. You need to take, if you're 50 or older, 80 to 1,000 of vitamin D3, and you should take it with dinner time, your major meal. And lastly, you must exercise 7 days a week. The exercise for osteoporosis is weight bearing. You're carrying your weight, your muscles and your bones against gravity. Secondly, do muscle strengthening exercise. Use free weights, bands, or machines. And lastly, try to learn yoga. Try to learn Tai Chi. It's free on television or on the internet. Does anyone have any questions?
We have a question in the chat box, Doctor. Drinking calcium fortified orange juice, does that qualify as a good source of calcium?
Well, it depends how much calcium is in. It'll say on the orange juice what percentage of calcium. They're basing it on 1,000. If it says 20% calcium, it means there's 200 milligrams of calcium.
So we have to do a little math to figure out.
You have to look at the bottle and see what percent of calcium. It's based on 1,000 milligrams.
Any other questions? Well, again, I think there were excellent takeaways, and I wish we could put you on television, Dr. B, and have you remind us of this every day, to take our calcium, our vitamin D, get that exercise, and remember to have our screenings and not to be afraid of treatment if it's indicated.
One ladies, if you have any subjects that you would like us to talk about at lunchtime, please let Teresa know, so we can have another lunch meeting in June.
Okay, well, thank you all for joining us today. Thank you, Dr. Benora. Excellent information as usual. And we look forward to seeing you all in a couple of weeks for our June lunch with the doctor.
Bye.